going back. However, if you do miss any of the questions or you want to review the content again, this presentation will be offered this afternoon as well as on Tuesday, Wednesday, and Thursday of this week. So without further ado, let's go ahead and get started. What are we going to be talking about today? So safe and effective care is what we're going to be focusing on. It is the first of the client needs. As you can see here, this screen shows the NCLEX categories and percentages as they break down. Both the left and the right-hand side of the screen do show the same thing, but in different ways. The left-hand side of the screen is a table that shows the client needs. There are 4 major client needs categories. 2 of them have subtopics. So we have safe and effective care environment with 2 subtopics, management of care, safety and infection control, which is what we're going to be talking about today. Health promotion and maintenance, psychosocial integrity, and then physiological integrity has the 4 subcategories: basic care and comfort, pharmacological and parental therapies, reduction of risk potential, and physiological adaptation. Now you can see how all of that breaks out in a pie graph as evidenced on the right-hand side of the screen with the different colors. So you can see some of them are larger. Management of care is at roughly 18%, whereas some of them are smaller. Basic care and comfort is about half of that at 9%. All right, so today we're going to be focusing on safe and effective care environment. The 2 subcategories for this are management of care, which is approximately 18%, and safety and infection control, which is approximately 13%. So what kind of topics fall under these? So when studying management of care, you're going to want to study things such as advanced directives, advocacy, assignment, delegation, supervision, case management, client rights, and concepts of management. 18% of the questions on the NCLEX exam will come from these types of topics. And then we have safety and infection control, accident and injury prevention, emergency response, home safety, ergonomic principles, safe use of equipment, and use of restraints and safety devices. And this is about 13% of those NCLEX questions. So those will be some of the topics that will be in our questions as we go throughout today's session. Now, if you haven't already, and especially for those of you who are just enrolled in the program, you need to access your Learn Upon account. Learn Upon is our online library. It's where we house all of those pre-recorded webinars that we have created for you. In Learn Upon, there is a webinar entitled The 6 Steps to Question Success. This is the way we here at Avant teach you how to work through questions methodically. Okay, there is a system, there is an approach to answering these questions correctly. The very first step of the 6 steps to question success is to determine the type of question. Here on this screen, we're showing you how to do that. When you're determining the type of question, we want to ask ourselves 3 things. What is the focus of the question? Meaning, what is it that the test question creator at the NCSBN wants us to do? Do they want to see if we can delegate? Do they want to see if we can prioritize? Do they want to see if we can... I apologize for sneezing. Do they want to see if we can therapeutically communicate? Do they want to know if we know the pathophysiology of a disease process? Or do they want to know if we can provide a teaching or an education plan to a client? So you have to ask yourself, what's the focus? Then you've got to say, okay, well, once I've determined the focus, what's my approach going to be? Is there a strategy that I can use, such as a decision tree, an apples and oranges question, an umbrella option, or a fixed versus flexible? Remember, guys, there are no absolutes in healthcare. So if you have a question with answer options that state something such as the client should always, or the client should never, you know that you can quickly eliminate those answer options as they will not be correct because there are no absolutes in healthcare. And then lastly, you ask yourself, well, what's the style of the question I'm dealing with? Is this a select all that apply? Maybe it's a highlighting item, which I think we'll do one of those today in our case study. Is this a drag and drop, a drop down, or a matrix grid? And if you're confused and you're like, oh my gosh, I don't understand what she's talking about with these approaches or these styles of questions, Please make sure you visit your Learn Upon account, as we do have webinars that explain each of these items. So therapeutic communication, this is something that we talk about in each and every one of our question clinics. It's so important, guys, not just on the NCLEX exam, but when you're working as a nurse at the bedside here in the United States. You have to know how to relate to people in this culture here in the US, which may be different than the culture that you're used to, and that's okay. Our differences are what bring us together and make us unique, but you also have to understand how to read people. So, responding to feelings and tone is going to be important. Providing our clients with information, with data, with evidence based practice, with what the research says. They don't want to hear your opinion, they want to know what are my odds? What does the research say about this? We want to stay focused on our client and what's happening with them and their situation. You want to make it all about the client. It's not about you, it's about them. We want to use silence and presence, guys. Silence is actually so therapeutic. When you combine silence with presence, it's powerful. It tells our clients that they are in a safe environment in which they are cared for. If they've just had a terrible diagnosis given to them, number one, they need time to process what that means. But number two, knowing that you are present and you are there for them speaks more volume than actual words do. So sometimes people say, well, that's awkward silence. Or people say silence is golden. And it is. Silence is so therapeutic when done in the presence of someone that you trust. We don't ask why questions. Why questions can come across as being probing, and we don't want to come across that way to our clients. We don't ask yes or no questions except for in the case of possible harm or suicide. That's the only time it's appropriate. Other than that, we need to be asking our clients open ended questions because open ended questions bond a relationship. Open ended questions further a relationship. It allows your clients and gives them permission to divulge information to you that they want to. And they can open up and they can share to the extent in which they feel comfortable. We don't want to explore. Again, exploring can come across as being judgmental. And we don't want to say, don't worry, because let's face it, we don't know what's going to happen in the future. And we don't want to provide our clients with a sense of false hope. Now, like I said, in your Learn Upon account is a 6-step strategy for question success. There is an entire webinar that teaches you about each of these steps, but I want to review them quickly before we begin question number 1. So step number 1 is to determine the type of question. Remember 2 slides back, we talked about this in determining the type of question. What kind of question is it? What's the approach? What's the focus? Step number 2, identify the topic. This is so important that you are identifying the topic correctly. We identify the topic as it's based on the instruction of the question and not necessarily as it's related to the story of the question. Step 3, looking for those keywords or clues that are usually in the story that will help you with your topic. Step 4, apply your knowledge. What do you know about this topic? What do you know about this diagnosis or this disease process? Step 5, you're going to begin to look at your answer options and you're going to begin a process of elimination using those strategies if they are applicable. And step 6, you're going to reread the question with the answer you've chosen to make sure that it actually makes sense. Alrighty, everybody. So let's get into our first question of the day. So question number 1 says, the hospitalized client diagnosed with end-stage cancer suddenly wants to discontinue treatment, including no tube feeding, mechanical ventilation, or antibiotics. When acting as an advocate for the client, what is the best response by the nurse? Number 1, respect the client's wishes and include them in the plan of care. Number 2, have the client share the decision with the family and notify the HCP. Number 3, withhold treatments the client wishes and clarify other treatments. Or number 4, decide what to do based on the client's needs when additional treatment is added. What is the best response by the nurse when acting as an advocate for your client. So I'm going to put 2 minutes on the clock here, guys, and mute myself. Please put that answer into the chat box, and I'll be looking at them as they're coming through. In 2 minutes, we'll come back together and we'll talk about it. So here we go. Alrighty, guys, so that was 2 minutes on the clock. The majority of you guys did indeed put the right answer. Have the client share the decision with family and notify the HCP. Now, we do have a tip because it says note the keyword suddenly, which indicates the decision is new. The nurse should act within the scope of practice and cannot discontinue treatment without an order from the HCP. All right, so now that we've talked about number 2 and why this is the correct answer, let's talk about the other ones. Number 1, number 3, and number 4. Why would these not be the best response by the nurse? So some of you did indeed put number 1. Let's talk about why that one is incorrect. Respect the client's wishes and include them in the plan of care. Although the client's wishes should be indicated on the plan of care, this nursing action does not demonstrate advocating for the client. Number 3, withhold treatments the client wishes and clarify other treatments. An HCP order is required to discontinue treatments, so you cannot withhold treatments. And number 4, decide what to do based on the client's needs when additional treatment is added. The nurse must act on the client's request when the request is made and not wait until additional treatment is prescribed. Alrighty, just looking through the answer box here to see if anyone had any questions. All right, I don't see any questions. Oh, I do have a question. So it says, advocacy means you're going to speak for the best interest of patient or convey his or her wishes. Yes. Okay, very good. Somebody also asked, what about confidentiality? So in advocating for the client, the nurse should contact the HCP and encourage the clients to share the decision with the family. To advocate for someone means to speak for that person when the person isn't able to speak for his or herself. The client is still able to make his or her own decisions, which will be better supported when the client shares this with the family and the HCP. So confidentiality here is not being broken. We are encouraging to have the client share this decision with the family and notify the HCP. Okay. Alrighty, guys. So let's move on to question number 2. So question number 2 says, somebody says, I personally think since there's an involvement in the plan of care, the HCP will be involved. Yes, the physician has to be involved in the client's plan of care. That's why we're notifying them. Alrighty. So question number 2 says, while the nurse is applying restraints to a client with suspected drug overdose who is combative, the client spits at the staff and the officer places a towel across the client's face. What is the most appropriate response by the nurse? All right, number 1. Once the client is properly restrained, the nurse responds to the officer. The towel must be removed. Number 2, the client is known to be HIV positive. The nurse responds, thank you for protecting us. Number 3, the nurse states the client must be treated with respect. Please remove the towel from the client's face. And number 4, the nurse tells the officer, please leave the room. I cannot allow you to treat the client in that manner. So, which one of these is the most appropriate response by the nurse when a client spits at the staff and the officer places a towel across the client's face? 2 minutes on the clock. Here we go. Alrighty, guys. So, coming back together, let me reveal the correct answer to you. So, the most appropriate response by the nurse in this scenario would be number 3. The nurse states the client must be treated with respect. Please remove the towel from the client's face. The client does have the right to respectful care. The nurse should intervene immediately by instructing the officer to remove the security towel from the client's face. So this would be the most appropriate response. Now, some of you did indeed put number 1, 2, and 4. So let's talk about why those would be correct. So number 1, once the client is properly restrained, the nurse responds to the officer, the towel must be removed. Although the client's behavior is distasteful, the client retains the right to respectful care. It is unacceptable to leave a towel over the client's face while applying restraints. Number two, the client is known to be HIV positive. The nurse responds, "Thank you for protecting us." The client's medical history should be on a need to know basis. There is no need to disclose this information because all staff should be using standard precautions. And number four, the nurse tells the officer, "Please leave the room. I cannot allow you to treat the client in that manner." If the security officer fails to follow the nurse's direction, the next step is to instruct the officer to leave the room. But this would not be the most appropriate response, as the help of the security officer is still needed to help in restraining the client. All right, excellent, guys. Let me just make sure there's no questions in the chat box before we move on. All righty, very good. So, question number three, moving right along. The nurse is caring for the client diagnosed with cystic fibrosis who is refusing to take a recommended nebulizer treatment. The client's refusal of treatment is classified as which of the following? Number one, a moral obligation. Number two, a legal obligation. Number three, an ethical right. Or number four, a basic human right. So, which of these is classified as the client's refusal of treatment? 2 minutes on the clock, guys. And here we go. Alrighty, guys. So, coming back together, the correct answer here to question number three is indeed number three. This is an ethical right. So, please note the tip at the bottom. It says you should select the option that includes the client's right to autonomy. So, ethical rights are based on an ethical principle and are often privileges allotted to individuals. So, let's talk about why number one, two, and four would not be correct. So, number one, a moral obligation. A moral obligation would be taking the treatment based on an ethical principle. Number two, a legal obligation would be one required by law. And number four, basic human rights. Basic human rights are rights based on the fundamental belief in the dignity and freedom of humankind. So, the question number three, the answer is number three, an ethical right. Just looking back through here, the questions already. Moving right along, question number four. So, question number 4 states the client who has a recurrence of breast cancer questions the female nurse about treatment options. Which response by the nurse would be appropriate? Select all that apply. All right, so we have our first select all that apply question. Now let's talk a little bit about select all that apply questions before I read through these answer options. Select all that apply questions on the NGN version of the NCLEX exam are partial credit, which means that you could get partial credit even if you don't answer the question entirely correct. That's what partial credit means. So the approach to these, when you are looking at a SATA question, you're going to work through your steps as you would with any other question. When you get to step 5, when you are looking at your answer options and you're applying your strategy, the strategy to a SATA question is to turn each one of these answer options into a true or false statement and provide yourself with that rationale for why you believe it is true or why you believe it is false. Okay, so when you do that, then you are reassuring yourself that you are choosing the correct answer options. There could be anywhere up to 10 answer options for a SATA question, and these can sometimes feel overwhelming to people because of the sheer number of answer options. But a lot of times, guys, SATA questions are straightforward knowledge content questions. So please make sure you are utilizing your 6 steps. You're turning each one of these into a true or false statement, giving yourself a rationale, and then selecting the correct answers. Now, if this is a negative query question and it wants you to choose all of the incorrect answers, then you would choose all the statements that are false. And again, we do have an entire webinar on Learn Upon that talks about SATA strategy. So I would encourage you to listen to that webinar. All right, so number 1, you should discuss your concerns with your oncologist. I cannot give you medical advice. Number 2, is there something your oncologist told you about your options you don't understand? Number 3, have you asked for a second opinion yet? There might be other options for treatment. Number 4, I can arrange a conference for you and your family with the oncologist. Would that be okay? And number 5, I know that if I had breast cancer, I would have both chemo and radiation. So, guys, with this question, not only are you having to figure out best responses, which would indicate this is a therapeutic communication question, but the style of the question is a select all that apply. So 2 minutes on the clock here, guys. Please put your answers into the chat box for me. And after 2 minutes, we'll come back together. So here we go. Alrighty, guys. So coming back together, let's reveal the correct answers here. So I'll bring them all up on the screen and then we'll talk about it. So the correct answers are the ones here in green. So 2 and 4. Is there something your oncologist told you about your options you don't understand? This response provides an opportunity to identify any misunderstanding that the client may have, provide and to provide an opportunity to teach. And then number 4, I can arrange a conference for you and your family with the oncologist. Would that be okay? With the client's permission, a meeting with the oncologist, the client, and the client's family may assist with the client's decision making regarding treatment options. So, some of you, though, did put 1, 3, or 5. So, let's talk about why these would not be correct. Number 1, you should discuss your concerns with your oncologist. I cannot give medical advice. The nurse may not give medical advice, this is true, but can listen to the client and advocate and teach where appropriate. Number 3, have you asked for a second opinion yet? There might be other options for treatment. The client has a right to a second opinion. But when the nurse makes the inquiry in this manner, it may convey a message that a second opinion is necessary rather than optional. And number 5, I know that if I had breast cancer, I would have both chemotherapy and radiation. It is not appropriate to impress our opinions onto our clients. Okay, alrighty. And question number 5. This is another select all that apply. So it says, which findings documented in the history of an older client should require the nurse to implement an accident prevention protocol? Select all that apply. Number 1, when range of motion is limited. Number 2, if peripheral vision is decreased. Number 3, transmission of hot impulses is delayed. Number 4, client reports incidents of nocturia. Number 5, high frequency hearing tones are perceptible. And number 6, voluntary and autonomic reflexes are slowed. So, when should the nurse implement an accident prevention protocol in the history of an older client? Alrighty, here we go. 2 minutes on the clock. Alrighty, guys. So, coming back together, let me reveal the correct answers here to you. And it would be all but 5. So, 1, 2, 3, 4, and 6. So the pathophysiological changes that occur during the aging process increase the client's risk for accidents. So number 1, range of motion is limited. Musculoskeletal changes include a decrease in muscle strength and function, lessen joint mobility, and limit range of motion. Number 2, peripheral vision is increased. Sensory changes, including decrease in peripheral vision and lens accommodation. Number 3, transmission of hot impulses is delayed. So, in the aging process, delayed transmission of hot and cold impulses can occur. Number 4, the client reports incidents of nocturia. Nocturia can increase as age increases, and this could lead to potential accidents. And number 6, voluntary and autonomic reflexes are slowed. Nervous system changes include slowed voluntary autonomic reflexes, and changes may include nocturia. So, number 5 is the only one that would be incorrect about high frequency hearing tones are perceptible. Impaired hearing as high frequency tones become less perceptible as the aging process occurs. So, again, guys, age related changes do occur on an individual basis. One client may experience an age related change to a lesser extent than another client. The nurse must gather baseline data and then assess for changes and determine the appropriate course of action to compensate to promote client safety. This is on an individualized basis. Okay. Someone has asked if I can explain number 4 further. So the client reports incidents of nocturia. So if your client is up in the middle of the night, if they're not able to sleep, they're wandering around their home, this could increase their opportunity, as you, I guess, would say, to have an accident. So if they're up wandering around in the middle of the night, they can't sleep, they're sleepwalking, they could, of course, have more accidents. So we would want to make sure that we are implementing an accident prevention protocol if they are reporting that they're up wandering around in the middle of the night. Okay. All righty. Very good. Let's move on to our case scenario. So, to simulate questions like those found on the NGN, which is that next generation NCLEX exam, as you will all be taking, we've created case studies like you would see in the real world. These cases reflect the kinds of critical decisions us as nurses have to make in a variety of healthcare settings. Case study questions ask better questions to help nurses think critically when providing care and making the right decisions. Learning and using critical thinking skills are the primary goals of the NCLEX exam. So questions 6 through 10 will be embedded in this case scenario. So the NCSBN has created this clinical judgment measurement model as a framework designed for testing. It complements the nursing process and other evidence-based theories or practices. New question types reflect real world nursing care using realistic scenarios or case studies, like you would see in a typical nurse client interaction, and focuses on the type of decisions nurses will have to make in the clinical setting. So, what is clinical judgment? Clinical judgment is a combination of the following. So, the first step in the nursing process, guys, is to recognize clues. We're saying what matters most with our client. The next step of the nursing process is to diagnose. This is steps 2 and 3 of the clinical judgment model. This is where we are analyzing clues. We're saying, what does this mean? And prioritizing hypotheses, saying, where do I start? The next step of the nursing process is to plan. This is step 4 in the clinical judgment model. This is when we're generating solutions. We're saying to ourselves, well, what can I do? The next step is to implement. This is where I'm taking action, saying, what will I do? And the last step in the nursing process is to evaluate. This is step 6 in the clinical judgment model. And this is when we're evaluating outcomes and saying to ourselves, well, did this help? Did it make a difference for my client? All right, so bear with me as I read through this case scenario. CK, a 71-year-old male, was brought to the primary clinic by his sister. The client developed a fever 2 days ago, complains of shaking, chills, a productive cough, and states he cannot lie down to sleep due to coughing. He is diagnosed with community acquired pneumonia and admitted to a medical unit at 11:30 a.m. The intern is busy and asks you to complete your routine admission assessment and call her with your findings. Your assessment findings are as follows. Temperature is 103 degrees Fahrenheit. Heart rate is 105. Respiration rate is 20. The blood pressure is 152/90. And the O2 stats are 92%. Auscultate decreased breath sounds and coarse crackles. The left lower lobe anteriorly and posteriorly. His nail beds are dusky. He has a productive cough with rust colored sputum and complains of pain in the left side of his chest when he coughs. He is alert oriented. He is a lifetime non smoker. The past medical history, which is that PMH, includes coronary artery disease, myocardial infarction with a stent, and diabetes mellitus. He is currently on metoprolol, which is also known as Lopressor, amlodipine, which is Norvasc, lisinopril, which is Zestril, furosemide, which is Lasix, and metformin, which is glucophage. So moving right along to the laboratory results. So we sent in a sputum culture, we sent in a blood culture, and we sent in ACBC with diff, all of which are pending. Medications, so D5 half NS IV at 125, ceftriaxone, also known as Rocephin, 1 gram IV Q12 hours. We have Alpunet, which is a nebulizer treatment, and it is every 3 hours. Physician has ordered him to be on a 2100 calorie diabetic diet, vital signs Q2 hours, monitor blood glucose with meals, and for a chest x-ray to be ordered. All right, so question 6. So the case scenario on the left-hand side of the screen is the same as from what I just read. Question 6 says, select 3 findings that require immediate follow-up. So are these findings going to be vital signs, lung sounds, client orientation, pain level, or the characteristic of a cough? So 2 minutes on the clock here, guys. Please put your answers into the chat box. We need 3 of them. And you can do 1, 2, 3, 4, and 5 if you would prefer to put your numbers versus typing it all out. So 2 minutes on the clock here, guys. There we go. Alrighty, guys. So coming back together, let me reveal the three that we should immediately follow up on. And for those of you who chose vital signs, lung sounds, and characteristics of a cough, you would indeed be correct. These vital signs indicate elevated temperature and respiratory rate, and O2 sats are abnormal. Lung sounds, these can help determine the severity of the pneumonia in worsening conditions. And the characteristic of a cough with thick sputum can definitely impair that airway. So these are the three we'd want to follow up on. Now, client orientation will be appropriate to assess if the condition worsens, but it's not the highest priority now, as it does state that the patient or the client is alert. And well, it would be number 4 here, but pain level. Pain level is not a priority here. All right, so we have some updates. So, initial chest x ray shows severe consolidation in the left lower lobe and a trace of pleural effusion. 4 days later, the chest x ray shows worsening multifocal consolidation in the right lung, and the MD order changes to vancomycin IV. Current vital signs: the temperature is 99 degrees Fahrenheit, heart rate is 120, respirations are 32, the blood pressure is 164 over 86, and our O2 sats are now 84%. We did have some lab work that came back. So the WBCs are 1430, platelets are 458, hemoglobin's 11.1, K is 5.0, phosphorus is 53. Oh, I missed chloride over there. Chloride is 103. Hematocrit is 32.3, sodium is 137, calcium is 91, BUN is 25, and creatinine is 2.1. And you can see some reference ranges over on the right-hand side of the screen. Medications, so we're still on the D5 half NS IV at 125. Vanco is now at 1,250 milligrams and 250 mLs of NS IV daily. We are still on the Alpunit nebulizer Q3 hours, and the physician orders our vital signs Q2 hours, still on a 2100 caloric diet, and monitor the blood glucose and the fasting blood glucose with meals. Question number 7 says to highlight lab values, the nurse should prioritize monitoring related to the use of an antibiotic. All right, so this is a highlighting option 1. Now, you guys do not have the opportunity to highlight, so I'm going to ask that you would just put your answers into that chat box for me. Okay, so you have some lab results here. You have a BUN, creatinine, Vanco peak levels, platelets, WBCs, creatinine clearance, and RBCs, and you have some reference ranges. So 2 minutes on the clock, type your answer into the chat. Which of these lab values should the nurse prioritize monitoring related to the use of the antibiotic in this scenario? 2 minutes on the clock. Here we go. Alrighty, guys. So coming back together, let me reveal the ones that you would want to follow up on. So vancomycin is the antibiotic here that we are dealing with. Vancomycin has usually been associated with nephrotoxicity, okay, kidneys. Generally, this toxicity is presented as proximal tubular cell injury with or without necrosis and as acute interstitial nephritis. So, not correct, guys. The ones we would not want to follow or need to follow up on related to the antibiotic would be let's talk about RBCs. So, Vanco does not affect blood RBCs or the platelets. So, WBCs, the WBC indicates worsening effect infection. Although we monitor the WBCs to see the effectiveness of the antibiotic, it is not directly related to the vancomycin. And then usually only vancomycin troughs are needed. Random levels may be obtained in patients with poor renal function. At minimum, levels should be obtained for all patients by 72 hours of therapy and at least weekly thereafter. So we wouldn't necessarily need to know vancomycin peak levels. Okay, so we don't need to know those. WBCs are not directly correlated with the vancomycin, and then the platelets and the RBCs is not something that is going to be affected because of the Vanco. So when we look at Vanco, guys, automatically you have to think of kidney injury at nephrotoxicity. So we would want to monitor the BUN, creatinine, and the creatinine clearance. Okay. Alrighty. And you are correct. We do not have a creatinine clearance as on the laboratory values. And that's okay. We don't necessarily need to know that for this question. What we need to know is which lab values we would want to prioritize monitoring related to the use of the antibiotic. Okay. All right. Question number 8. So CK is receiving treatment for pneumonia and is still experiencing hypoxemia. The nurse understands that respiratory acidosis is common in patients with pneumonia. The question 8 says, which arterial blood gas, ABG, which reading represents uncompensated respiratory acidosis? All right, so we have an ABG question. All right, we will do ABG interpretations on the next slide. We'll talk about it a little bit more. But uncompensated respiratory acidosis. Is it going to be number 1, a pH of 7.29, a PaCO2 of 55, an HCO3 of 23, or a PO2 of 85? Is it going to be number 2, a pH of 7.48, a PaCO2 of 35, an HCO3 of 22, or a PO2 of 85? Number 3, a pH of 7.2, a PaCO2 of 20, HCO3 of 28, PO2 of 85, or number 4, a pH of 7.55, a PaCO2 of 63, an HCO3 of 19, or a PO2 of 85. So 2 minutes on the clock. Which of these represents uncompensated respiratory acidosis? Alrighty, guys. So for those of you who love ABGs as much as I do, you would know that number one is indeed the answer. So number two and number four can quickly be eliminated because these both represent alkalosis because of that pH level. Now, then that leaves us number one and number three, and then we can go between a PaCO2 of 55 or a PaCO2 of 20. And number three does indeed represent metabolic acidosis. So when we are looking at uncompensated respiratory acidosis, that would indicate number one would be the correct answer. So for those of you who need a refresher, for ABGs, let's look at these normal values. So normal pH is 7.35 to 7.45. So the number two and number four, 7.48, 7.55, that is going to be an higher than expected pH, which is going to tell us that it is representative of alkalosis. So the lower 7.29 and 7.2, that's less than the 7.35, which is going to represent acidosis. Okay. When we're looking at a CO2, we see that the reference range is 35 to 45. So when we're looking between number one and three, we see that we have a PaCO2 in number one that is elevated and a PaCO2 in number three that is below the expected value of 35 to 45. Then you have a PO2 of 80 to 100. That's your normal reference range. Each one of these is at 85, so they all fall within normal. We have an HCO3, which is that bicarb of 22 to 26. So as we can see in number one, we have a bicarb of 23, which is within that reference range. But number three has a bicarb of 28, which is elevated and outside of the reference range. And then we have a O2 set. Normal is 95 to 100. So let's talk about interpreting ABG. So just a quick, rapid review. So this is rules for rapid clinical interpretation of ABG. So there are lots of resources online, guys, to help you to better understand ABGs. But for the purpose of NCLEX, you should just focus on recognizing the values. So we have to say to ourselves, is there a problem? What is the problem? And then what is to blame? So we think of the mnemonic ROME. Respiratory is opposite, while metabolic is equal. If there is a respiratory issue, the pH and the CO2 will go in opposite directions. If it is a metabolic issue, the pH and the bicarb will go in the same direction. So is there a problem? You look at the pH. If it is less than 7.35, it's going to be acidosis. If it's greater than 7.45, it's going to be alkalosis. Then we have to say, well, what is the problem? If it's acidosis, we have to ask ourselves, is the CO2 elevated or is the bicarb decreased? If it's alkalosis, we have to ask if the CO2 is decreased or if the bicarb is increased or elevated. When we go to the next step, we're saying, well, what's to blame? If we're looking at acidosis, are we saying, is it respiratory, as in the CO2 is elevated, or metabolic, as in the bicarb is decreased? If it's alkalosis, we say, is this respiratory alkalosis, meaning that the CO2 is decreased, or is this metabolic alkalosis, as in the bicarb is increased? So quick little review there for the interpretation of ABGs. Always start with your pH. All right, so question number 9. So our case study says that he was diagnosed with pneumonia, started on Vanco, and he's still experiencing hypoxemia. Current vital signs are as follows. So the temp is still 99, heart rate's 120, respirations are 32, blood pressure 164/86, and the O2 sat is at 84%. The ABGs read as follows: 7.29, PaCO2 of 55, HCO3, which is that bicarb of 23, and the O2 is 85. Medications remain the same, as do the physician orders. So, question number 9 says complete the following sentence by choosing from the list of options in the drop down menu below. So, it says the nurse recognizes the patient is showing signs of blank and continues to monitor blank and take action to blank. So, the nurse recognizes the patient is showing signs of embolic stroke, acute MI, COPD, or respiratory distress. So I'm going to give you guys 1 minute on the clock. Just put that into the chat box for me. All right, so we recognize that the patient is showing signs of respiratory distress and continue to monitor the vital signs every 2 hours, confusion and extreme tiredness, daily weights, or ECG changes. Which one, guys? Alrighty, so we continue to monitor confusion and extreme tiredness and take action to restrict fluids, apply 2 liters O2 via nasal cannula, raise the head of the bed and maintain proper body alignment, and administer cough suppression. Which one? And it is going to be raise the head of the bed, maintain proper body alignment. So let's talk about why these are correct. So the nurse recognizes the patient is showing signs of respiratory distress. CK progression is worsening with a chest x ray and vital signs and a decreased O2, and ABGs all point to signs of respiratory distress. We continue to monitor for confusion and extreme tiredness. um, Confusion and extreme tiredness indicate a decreased O2 to the brain, and stress, especially with patients that are over 65 years of age. Why not correct the vitals? A lot of you said vital signs. The vital signs should be checked every 15 to 30 minutes for patients in respiratory distress. Monitoring the vitals every 2 hours is just not enough. And then ECG changes was another one. Changes will be appropriate, but not the proximity and respiratory distress. The focus should be on oxygenation and ventilation. And then number 3, raise the head of the bed, maintain proper body alignment, allows to improve lung expansion and prevents aspiration. If we put the patient on 2 liters of O2, that's simply not going to be enough, guys. If your client or your patient is at 84%, they're going to need to be on more oxygen than that. So probably about 5 liters and possibly even a mask. So instead of just nasal cannula. So we would want to take action to raise the head of the bed to help maintain proper body alignment, to improve that lung expansion, and then to, of course, prevent aspiration. And the last question of the day: which of the following patients or clients is most at risk for developing pneumonia? Select all that apply. Number 1, a 53-year-old female recovering from abdominal surgery. Number 2, a 69-year-old patient recently received the pneumococcal conjugate vaccine. Number three, a 42-year-old male with COPD and is on continuous oxygen via nasal cannula. Or number four, an 8-month-old with RSV infection. So 2 minutes on the clock. Who is most at risk for developing pneumonia? Select all that apply. Here we go. Alrighty, everybody. So revealing the correct answers to you. It's going to be number one, number three, and number four. So risk factors for pneumonia include recent surgery, lung disorders such as COPD, and viral infections such as RSV. Option number two, the 69-year-old patient recently received the pneumococcal conjugate vaccine. This is a preventative measure in preventing pneumonia, not causing pneumonia. So the correct answers 1, 3, and 4. Alrighty, guys, so that is all that we have for today. Thank you so much for coming to Question Clinic. I hope you learned at least one thing. Maybe if you haven't done ABGs in a while, they were in the very back of your brain and had to pull them forward. Make sure that you are reviewing those. But thank you for coming. If you missed any part of today's session, you are more than welcome to join this afternoon session or Tuesday, Wednesday, or Thursday. So again, thank you guys for coming, and I hope that you learned a lot. Have a fantastic rest of your day. Take care.